Welcome to the Cardiovascular Pulse, where we dive into medical breakthroughs, leading technology, and healthy lifestyles. Join us as we empower you on your journey to a healthier and stronger you. Today, I am joined by Dr. Sandeep Patel. He is an interventional cardiologist at the Cardiovascular Institute of the South in Thibodeau. And actually, we were just talking how he's been with us here at CIS in Thibodeau for almost 29 years. Welcome, Dr. Patel.
Thank you for having me. It's valuable for us to discuss various cardiac topics.
Today, I know that we are going to talk about chest pain. I know that chest pain is the most common symptom that patients present with if they have any type of cardiovascular disease. So, we're going to break that down and discuss the different types, how to know if you need to go to the ER for your chest pain, and all of these different variations. So, first of all, Dr. Patel, tell us what is chest pain and what might it really feel like?
So, chest pain can be very severe, such as crushing, like some elephant or somebody sitting on you, pain going from the chest to the jaw, down the arms. When it's like that and it's not going away right away after 5, 10 minutes, it's best to go to the emergency room for evaluation. But chest pains can be also sometimes neck pains, shoulder pains, upper back pain, sometimes off and on pains that may need not to go to the emergency room right away, but can be evaluated further in the office setting.
I see. So it does depend how long the chest pain is going on for. Is that correct?
Not only the duration, but how severe it is. If you have pain, and we go by a scale when we're asking patients whether no pain being 0 or the most severe pain being 10. If the pain is severe, it is more in the middle of the chest, going toward the neck or going down the arms. Those are the pains that may need better evaluated in the emergency room.
If someone comes into the clinic here with some mild chest pain, how are they typically evaluated?
So almost every patient with chest pain gets evaluated by common vital signs such as blood pressure and pulse. Also, we do an EKG, electrocardiogram, on every patient that comes in with chest pain or associated symptoms or such, because that gives us an idea of if they're having any acute changes on the electrocardiogram or no changes or no change from previously.
If someone presents to the emergency room, is it the same type of process or is it different?
So, emergency room, depending upon the severity of symptoms, again, the EKG is the first thing that is done. Also, in the emergency room, they will probably check some blood tests that indicates where a patient is having a heart attack or acute coronary syndrome. And from there, and given some medications and such, symptoms persist depending on what the blood test showed, the EKG. If they're having something called an ST elevation myocardial infarction, where the artery is totally blocked to one part of the heart muscle or not, they may have to be taken urgently or emergently to the cardiac cath lab for possible angiogram, possible balloon, possible stents.
At that point, an intervention is
Is
needed to
necessary.
take
Take
care
care.
of it.
And time is muscle, meaning earlier you get to the emergency room with severity of chest pain, earlier they can diagnose, and we'd like to be in the cath lab within 60 to 90 minutes of onset of symptoms.
Since it's so important to be seen right away, how would a patient know if they should be seen? I think sometimes they think they might just have heartburn or some other symptom or indicator. So, how do they know the difference?
So sometimes we don't know the difference. Sometimes heartburn can be truly heartburn or acid reflux, but heartburn can also be a sign of significant blockage or symptom. And if heartburn occurs more with exertion, more with activity, then it can be more cardiac related. If heartburn occurs every time you eat pizza and sauce, that may be more GI symptoms. And some patients have both. They have heartburn, hiatal hernia, acid reflux. At the same time, they're developing blockages also. And chest pain being one of the most common signs, it goes to the emergency room at least 10 million times. Patients go per year with chest pain. In the office, it's about 4.5, 5 million times. And the patient's been having symptoms off and on for a time, they have other risk factors, and it's not persistent or worse, they would get further evaluated in the office. Also, if they go with chest pain to the emergency room and the blood tests are negative for any heart attack or some blood test called troponin that rises with a heart attack, then they can be discharged and further evaluated in the office setting.
Now, are there any risk factors that may vary when someone's dealing with chest pain to make them more at risk, such as age, gender, things like that?
So the most important risk factors include family history, which can be up to 40 to 50% of risk. Meaning, if you've had a father or a mother that has premature heart disease, father before the age of 55, mother before the age of 65, whether they've had blockages in the heart or a stroke or in the legs, then you have to be evaluated early on. Meaning, when you hit 30, 40 years of age, important to get checked out. Even younger, maybe get that cholesterol checked out. And besides having parents who might have had that, siblings, if you've had a brother or a sister who've had heart disease at a younger age or similar ages, you want to be checked out early also. Besides those, the risk factors of smoking, very important, which has gone down in this country from 40% of people used to smoke in the 1960s. In fact, some of the surgeons even smoked in the operating room, or smoking was allowed in the airplanes. But nowadays, the rate has gone down to about 16, 17%, which is improved for the whole population, but it's still cumulative. And smoking has increased over the years in women. So besides smoking, high blood pressure is very important risk factors for heart disease. Diabetes, very important. And unfortunately, in our South Louisiana, in the diet that we have and the weight that we have, diabetes can be up to 20 to 25% of the population having diabetes. Other things that can be risk factors include high cholesterol. And such risk factors need to be checked and corrected so that patients don't develop heart attack. Our whole goal of prevention is to catch it before you have an event. Or
Sure.
if you do have an event, how to prevent second events from happening. For example, symptoms can be different in both men and women. Men come in with chest pains, and women also come in with chest pains. 90% of people who have a heart attack or acute coronary syndrome have chest pains. But women tend to have more associated symptoms. They may have more nausea, more sweating, more upper back pain, more gas pains. Men typically have more chest pains. People who get pain with exertion, like when they're washing their car, cleaning up, or lawn mowing, especially in this area where mowing the lawn is very important, they need to be evaluated. The elderly patients may not get chest pain. Those over the age of 75 tend to get more other type of symptoms. Could be just nausea, could be confusion, things of that sort. So those over the 75, if they come with other symptoms, they may still need to be evaluated for heart disease.
There can be so many indicators in addition to the chest pain to know when you have something that needs to get checked out. So it's
Right.
just important to get checked out if you're not sure.
Sure. And besides chest pain, shortness of breath can be a major symptom. People say, for example, you were able to walk a mile a day, okay? But now after a half mile, you get short of breath or you sit down, you have to rest. Those things need to be checked out. Shortness of breath can be symptom of heart problems, they can be symptom of lung problems, but they need to be checked out. In the office setting, after an EKG, we may do a test called an echocardiogram that involves ultrasound of the heart to check what the pump function is, what the valves are doing, make sure there's no damage to the heart muscle. We may also do something called an exercise treadmill stress test if patient is able to walk adequately, get that heart rate up to 85%, see if we see some changes on the electrocardiogram. Those that cannot walk, and if we have to evaluate, we can do something called pharmacologic nuclear perfusion study, where we give medication that acts like exercise. And we can get enough information to see which parts of the heart is or is not getting enough blood flow. It is important to note that a regular stress test is only about 70% sensitive in detecting significant blockage. A nuclear perfusion study is about 85% sensitive. And we in our Thibodeau clinic also have the capability of doing coronary CT angiogram, where patients, if they're indeterminate, they're like borderline, or we don't get enough information with the nuclear study, and they're still having symptoms, we may do this coronary CT angiogram, where we involve dye that is given through the vein, take hundreds and thousands of slices of the heart to see where and how much the blockage is. And this is somewhere about 90 to 92% sensitive. And then if any of these are abnormal, whether it's a stress test with chest pain, the nuclear study abnormal showing some reversible abnormality, or the coronary CTA, which shows possible significant blockage, then patient would have to go for cardiac catheterization or angiography of the heart arteries to see where and how much the blockage is.
It's amazing, truly, that all of these advanced diagnostics for cardiovascular disease are right here at CIS in Thibodeau.
Absolutely. And our most recent, we've had PET studies, which have been there for the last 4 or 5 years, but we've added the newer edition of a PET CT studies that can tell us what kind of flow is getting into different parts of the heart muscle, even before the angiogram. More sensitive, more specific, and gives us a better idea.
So we would say if you have any concern about the symptoms you might be feeling, if anyone listening experiences a feeling of chest pain or maybe some of these more subtle symptoms, it's so important to see a cardiologist. And feel free to come see Dr. Sandeep Patel at CIS in Thibodeau.
Absolutely. Not only myself, we have many colleagues here that specialize in many things, and we'd be happy to see you for cardiovascular evaluation.
Thank you, Dr. Patel, for joining us today. That was very insightful.
Thank you.
We hope that this has empowered you on your health journey. If you have health concerns, visit cardio.com to learn more or request an appointment. Make sure to follow this podcast as well as CIS on social media for updates. Thanks for listening.